He practices at Jamshedpur, Jharkhand, and today he's here to present to us a very interesting topic and the current scenario on COVID-19 and sugar tension. I would request Dr. Virmani to start his session. Sir, over to you.
Good evening, friends, and thank you, Dr. Sanket, for the nice introduction. Today, we are in the midst of an unprecedented crisis. Never before in the history of mankind has a single tiny virus, this 127 NM COVID-19, brought the world to its knees. It is proclaiming loudly, Puri Dunya Muthi Mein. So, friends, it is indeed a crisis that we have to take care of. And those of us who are practicing diabetology, our patients with diabetes are the most effective, and I will be covering that. I have coined a term called sugar tension. It is not there in the dictionary. It is basically, it just tells us about a bidirectional relationship. We all know that COVID-19 is more likely to affect elderly, uncontrolled diabetic patients. And unfortunately, patients with diabetes are more likely to have severe complications and a higher fatality rate. So-called tension, that is from the stress, which may be because of the fear of infection or infection per se, or the mental effects of the social isolation that we are undergoing at the moment. This can lead to glycemic instability and blood pressure fluctuations. The so-called lockdown that has resulted in a marked glycemic variability amongst a lot of my patients. Why? For the simple reason that today there is almost no opportunity for going for regular walks. Gyms are closed, and when you tell a person to do exercise at home, there are a lot of issues. Of course, the social isolation itself has led to a lot of mental stress and anxiety. There is an inappropriate dietary behavior. People are having excessively their eating. There may be scarcity of fresh vegetables and fruits. There is high use of packaged foods, which may be high in calories, fats, and trans fats. And the biggest problem is that there's a difficulty in procuring the anti-diabetic drugs, insulin, needles, glucose strips, etc. Moreover, those who are elderly and staying alone in the home are facing a maximum brunt of the problem. And as we all know, in all diabetics, in case of an infection, which is, as it is, they are prone to infections, there is increased risk of hypoglycemia and ketoacidosis. But before I go ahead, it is said that if you want to win a war against your enemy, know thy enemy. So let us see who is this COVID-19. This coronavirus disease 2019, which has been termed as COVID-19, is an infectious disease, and it is caused by the most recently discovered RNA coronavirus called SARS-CoV-2 or the beta coronavirus. It grows in primary human airway epithelial cells, and the cellular receptors are the human angiotensin converting enzyme 2. This new virus and disease was unknown earlier, before the outbreak began in Wuhan, China in December 2019. Since then, it has led to a pandemic, and on 11th of March of 2020, it was declared a pandemic by the World Health Organization, which basically means more than 100,000 cases in more than 100 countries. So you can imagine, and how does it spread? A close personal contact with an infected case, like touching or shaking hands or hugging, and then touching your mouth, nose, or eyes before you wash your hands. Touching something with the virus on it, what we call as fomites. There may be objects and surfaces, lift buttons, doorknobs, and then you touch your mouth and nose or eyes again before washing your hands. People can also contract COVID-19 if they breathe in droplets from a person with COVID-19 who coughs out, sneezes out, or exhales droplets. So it can spread by droplets also. And if you look at the surfaces on which it persists, on plastic, it can persist for more than 5 days, on paper for 4 to 5 days, glass 4 days, wood 4 days, steel 48 hours. So you remember this is important. The knobs of the taps in our bathroom, it can persist for 48 hours. Even on the surgical glove for 8 hours. This is a global scenario indicating the dark areas indicating where there is a very high incidence. And this is our own country, India, where at the moment we are lucky not to have so many cases, but we are very optimistic at the moment. It is basically causes, if you look at the pathogenesis, it is basically causing an immune damage to the lungs. Now, this virus has got a spike, and this S protein then enters into the cell and starts replicating in the cytosol. Once it starts replicating, it does antigen presentation to the macrophages epithelial cells with release of number of cytokines from the T cells and beta cells, that is our cellular and humoral immunity. Of course, diagnosis of COVID-19, the ideal gold standard has been the reverse transcriptase polymerase chain reaction and high throughput sequencing, but there are CT scans and point of care body antibody testing, which I'll come to a bit later. There has been a recent hypothesis where it is said that the COVID-19 attacks the 1 beta chain of hemoglobin and captures the porphyrin to inhibit human heme metabolism. So there are certain proteins on the coronavirus, the ORF8, the surface glycoproteins, and they combine with porphyrin to form a complex. The other proteins attack the heme on the 1 beta chain of hemoglobin to dissociate the iron to form the porphyrin. That means there is less amount of hemoglobin to carry oxygen and carbon dioxide. So the lung cells, since they are derived of the benefit of the oxygen, they have extremely intense inflammation. And because the exchange of oxygen and carbon dioxide is not possible. And this represents as ground glass like lung images, which are classically seen on the chest X-ray and CT scan. A person who's having respiratory distress will definitely be worse off. Now, similarly, patients with diabetes and older people have a very high glycated hemoglobin, and this is reduced by the attack, which makes the patient's blood sugars unstable. Since the porphyrin complexes of the virus produced in the human body inhibit the heme anabolic pathway, they can lead to a wide variety of infections and disease. Those still hypothesis is worth considering when you think about why diabetics are affected more and why chloroquine is showing good effectiveness in the treatment. How to evaluate these patients? Now, we must consider COVID-19 in a patient with history of fever, cough, shortness of breath, and a high risk of travel or exposure in the previous 15 days. This is classical, but one must remember that there can be unusual presentations. Fever that is seen in more than 75% of hospitalized cases, but 50% may remain afebrile on admission. Cough may be either dry or productive and may be seen in 60 to 80% of the patients. There may be symptoms of breathlessness and in only 20 to 40%. And some patients may have GI symptoms like diarrhea. Recently, it has also been stated that one of the earliest symptoms may be loss of taste or loss of smell. Now, what investigations we would like to do? Of course, the routine investigations. When we do a complete blood count, we are basically looking at leukopenia and lymphopenia. So the lymphopenia is very, very important. It gives us a clue to the presence of COVID-19. And it is seen in almost 33 to 85% cases. However, you may see leukocytosis in less than 5% cases. There is an increase in the AST-ALT ratio, CRP is increased, and the procalcitonin is also increased. Now, if you want to do a macrobiology, it is basically to rule out the absence of other bacterial pathogens because most of these patients may be co-infected with other bacterial pathogens. Now, how to recognize which patients are serious and require urgent attention? These are the patients who are going to have difficulty in breathing or shortness of breath. They'll have persistent pain or pressure in the chest. They may have a new confusion or inability to arouse, and the lips may become bluish or face may become bluish because of the hypoxemia and cyanotic conditions. Let us look at the natural history of COVID-19. The incubation period is around 4 to 6 days with a median of about 5.1 days. Then there is an acute mild phase lasting about 5 to 10 days, and this consists of non-specific symptoms, the one I mentioned like fever, cough, myalgias, fatigue, nausea, diarrhea. And then the patient passes into the ARDS, pro-inflammatory phase, or what is known as a cytokine storm, where the hallmarks of dyspnea, tachypnea, and hypoxemia. He may recover or he may die afterwards. Now, in patients who have no symptoms, it is very important to realize that 30% patients who may remain asymptomatic may remain contagious even during the period that they are immune, even though there is no mortality in these patients. Patients, 55% maybe have mild to moderate symptoms. They may remain contagious almost till 21 days, whereas the asymptomatic patients may remain contagious till 14 days. Those who have severe symptoms, they require hospitalization and then they perhaps get immunity, but they are contagious throughout their entire stay. And so is with the contagious, those 5% with the critical symptoms. The mortality rate in severe symptoms is around 15%, and those with critical symptoms is around 50%. Now, what are the risk factors for severe COVID-19 disease? Of course, if you look epidemiologically, the elderly people, those who have pre-existing pulmonary disease, chronic kidney disease, diabetes, hypertension, cardiovascular disease, those who are on immunosuppressants or have had a transplant. Now, there are certain vital signs that one person looks at. There will be tachypnea with a respiratory rate of more than 24 per minute. There will be tachycardia, heart rate more than 125 beats per minute. The saturation of the oxygen will be 90%, less than 90%. And there may be, the SOFA score is the one that goes for the multiple organ failure. When you go for the lab diagnosis, the D-dimer is the one that tells us, which is more than 1,000 nanograms per ml. And this is a very, very important sign indicating the severity, but there may be elevated CPT, CRP, LDH, troponin, and ferritin, as well as the cytokine IL-6. The lab diagnosis of COVID-19 is very interesting. There are two types of tests. The gold standard is, of course, a reverse transcriptase polymerase chain reaction that detects the viral RNA, and this is for confirmatory diagnosis. Then recently we have developed rapid tests for antibody detection, and they have been approved by the Indian Council of Medical Research. But we should know the pitfalls. The pitfalls of PCR are the sensitivity rate is 70%. So it is dependent on the methods that the one who is doing PCR with, and 30% may give you a false negative result, even though it is the gold standard. Moreover, the sensitivity decreases after 1 to 3 days post-symptom onset. It is more than 90%, but from day 6, it is 80%, and day 14, it is less than 50%. So as days pass, the sensitivity of PCR goes down. Now, this is low viral load in the late phases or incorrect sample collection and processing can lead to false negative. So another important thing is that the process of sample collection produces aerosols, and this can lead to potential health risk to the collector. It is time consuming, requires expertise, leads to delayed reports, minimum 24 to 48 hours, and it is costly. So the ICMR came out with the rapid antibody test, where we are testing for the IgM, G, and A from the beta cells against the receptor binding domain of the transmembrane glycoprotein spike, or the S protein, or the nucleic acid N protein. Now, the seroconversion in infected grades after 15%, if you look, all the three antibodies will be present 100%. IgM is seen in 94.3% and IgG in 79.8%. It can be tested either by the enzyme-linked immunosorbent assay or by the immunochromatography or the CART test. It has got a high sensitivity of 87.3% with ELISA and 82.4% with immunochromatography, but the specificity is 100% in both. The positive detection rate is only around 52% in a single PSR test, but when you do an IG and ELISA along with it, the sensitivity goes up to almost 99%. So both these tests would be an ideal. And this just shows how the PSR sensitivity decreases with time and how the antibody level sensitivity increases with time. What is the strategy? The ICMR recommended earlier that in those people who are a cluster or containment zone, or there are large migration gatherings and evacuation centers, and who are symptomatic with an influenza-like illness, whether it be cough, cold, low-grade fever, or sore throat, they should go for a rapid antibody test and home quarantine for 14 days. And if the rapid test is positive, they are probably COVID-19 positive and they require either hospital treatment or home isolation. If it is negative, then go for an RT-PCR, and if it is positive, again the same COVID-19 positive, hospital or home quarantine. If negative, it is non-COVID influenza-like illness. But if it is negative initially, then if the PSR is not done, at least let them go for home quarantine. Repeat the antibody test after 10 days. If negative, they are non-COVID, and if positive, they have to be taken as a proven case of COVID-19. Now, if symptoms worsen, no matter what the test report, they must immediately be admitted in a center designated for COVID-19 cases. Now, yesterday, the 9th of April, the ICMR has come out with version 4 strategy, which along with the previous 4, which were there already, now they are recommending that asymptomatic, direct and high-risk contacts of a confirmed case should be tested once between day 5 and day 14 of coming in his or her contact. Asymptomatic persons. Earlier, it was only symptomatic persons. And moreover, in those from hotspots and clusters, all symptomatic patients have to be tested within 7 days for through the PCR method, and after 7 days through the antibody test method. And if this antibody test is negative, it must be confirmed by a PCR method. Now, this is why, if you look at this, the history, this is what is happening at the clinical stage. And this is when the IgM level comes detectable around the 6 to 7 days, and then goes down by 21 days. And then around the 14th day, the IgG antibodies start to rise and may remain in the blood, indicating long-term immunity. Therefore, a rapid test should not be performed before 5 to 6 days at least. And this is what is meaning when the PCR is positive, patient may be in the window period of infection. And when PCR and IgM is positive, patient is in the early stage of infection. Later on, the IgG remains positive, whereas the PCR becomes negative. Now, if you are not able to do a PCR because of the lack of facility, there are certain clinical findings which can give us clues that this may be a patient of COVID-19. Abnormal CT findings, the classical ground glass images are seen in 86%. Lymphopenia is seen in 83%. Platelets less than 150,000 in 36%. Increased CRP, procalcitonin, LDH, AST-ALT elevated, elevated bilirubin, and of course D-dimer. So there are certain clues which can give us from the clinical and lab criteria. There's some very interesting facts. The mortality rate is 15% in the elderly, whereas overall it is 2.3% as per the data available from China. Men, unfortunately, are 2.4 times more likely to die compared to women. And this is the Italian data. Why? We don't know exactly, maybe some genetic predisposition. 30% of the cases are likely to be hospitalized. 4% will require admission into the intensive care units. Viral load peaks at the time of symptoms. So transmission can occur even in the asymptomatic stage. That is very, very important. And we have a number known as R naught. R naught is the reproductive number, which basically means one person can infect how many persons. According to the Italian data, the ratio is around 2.7 to 3.25, which basically means that approximately 3 persons can be infected by one person who may even be asymptomatic. And if you go till the end of the month, when these persons start infecting, so that one index case can infect more than 400, to be exact, 406 patients in 1 month. Now this R naught number is very important for us because it can be reduced by physical distancing, and that is the crux that we are attacking. Herd immunity. People have talked about herd immunity. Some say that maybe 40 to 60%, some say no, 60 to 70, some say more than 70%. When that much population is affected, it can slow down the pandemic. But to develop herd immunity, it requires time, and it may be risky. There may be increased fatalities. So we cannot wait for herd immunity to take over and rest assured. We have to have measures to contain this virus immediately. Now, how to prevent? That is very important. When there are no cases in your area, then you take the universal population measures, apply the routine hygienic measures. And if there are sporadic cases, we start case isolation and management and quarantine for those who have been in close contact with this sporadic case. But when a cluster of cases occurs, then you have to suspend public gatherings. And when community transmission occurs, total movement restriction or lockdown has to be done. Now, we talk about travel restrictions. Yes, travel restrictions are good, but they alone are not sufficient. In fact, if you really want to reduce, you have to have physical distancing or social distancing. And what do we mean by social distancing? It basically means that we avoid close contact between people so that we slow the spread of the infectious disease. So what should be done? Avoid group gathering, play dates, sleepovers, athletic events, concerts, movie theaters, non-essential workers in your house, crowded stores, malls, gyms, and mass transit system. This should be absolutely locked down. And we should have very big caution when visiting a local restaurant or a grocery store, or taking out a takeout delivery, or even while picking up our medications, playing tennis in a park, visiting library, going for religious function, or traveling. What is safe? Take a walk, preferably within your house or your garden. Do some yard work, play in your own yard, clean out the closet, clean your house, cook a meal, listen to music, bond with your family. You can have video chats. You can talk to your friends. So these are important. Now, what is the importance of social distancing? Why? The main aim is we cannot prevent viral disease, but we can delay it so that with protective measures, the healthcare system capacity rebounds so that we can take care of these patients when they get sick later on. So basically, it is known as flattening the curve. Now we are flattening the curve so that we can take care of these patients later on. The next question comes, how long a lockdown should be there? And we are very fortunate that our Honorable Prime Minister decided long time back, about 17, 18 days back, to go for a 21 days lockdown. And look what happens if you go for 21 days lockdown, the transmission rate goes almost down. And then unfortunately, when you lift the lockdown, there is going to be a spurt of cases. And if you lock down again for another 28 days, this spurt can be stopped. And if you lock down for another 18 days, you can bring it down. So either you can have a staggered lockdown where you have spurt of case and then you again have a lockdown, or you have a continuous lockdown for 49 days, and then perhaps if you have a lockdown till say 15th of May, you may be able to get over this coronavirus. Now, this decision has to be taken by the central as well as the state government. But statistics shows that it is better to go in for a longer lockdown so that we can contain this virus at this stage. Now, why social distancing was important? I'm reminded of what Benjamin Franklin said once. For the want of a nail, the shoe was lost. For the want of a shoe, the horse was lost. For want of a horse, the rider was lost. For want of a rider, the battle was lost. For the want of a battle, the kingdom was lost. And all for the want of a horseshoe nail. So one simple horseshoe nail, because of that, the whole kingdom was lost. So just because we don't maintain physical distancing between each of us for the next, say for about 21 to 48 or even 49 days, our whole life may go. This virus may be a habit. That is the important. Now, there is something called temporal separation. I must clarify what is temporal separation. Now, we know that we live in a society where there are certain groups of people who cannot be separated in space because of the nature and work that they have. So they have to be separated in time. Let's take an example. People, our healthcare workers who are working in the COVID-19 team, taking care of the patients, they cannot have physical isolation. So what do? We allow them to work for 1 week, then ask them to go for home quarantine for 2 weeks. If there are no symptoms, they return to work. On the other hand, there are also health workers who may not be in the COVID-19 team, and there will be others like who are giving us grocery, who are taking care of our sanitation, and there are so many people. Now they should be allowed to work on day 1. They should take home quarantine from day 2 to day 7. Now this is mandatory, and why it is mandatory? Because this is the minimum period of 1 week. This will allow detection of cases within the person and simultaneously break the cycle of transmission to his colleagues. The basis is that most patients with the disease present with symptoms within 2 to 5 days, though it may take 14 days. So at least a 2 to 7 days quarantine is very important. And if they have symptoms of COVID, then they should, of course, depending on mild to moderate, they can go for home quarantine, or severely critical, they can be admitted in the COVID designated area. In case they have no symptoms of COVID, they can return to work on day 8. This is what is meant by temporal separation. Now, what is the Indian scenario? Let's see what is the Indian scenario. Now, there are 3 possible things that can happen. One, a very high trajectory with the current lockdown, but insufficient physical distancing or compliance. And we have seen this spurt in cases because of 2 very things, the migrant laborers and clusters of a religious gathering. So if this thing happens, then the cases are going to go very high. The other is medium, which is most likely scenario with moderate to full compliance. You may not have full compliance, but yes, sufficient compliance, and the virus, there is no change in the virulence of the virus or temperature or humidity. And the most optimistic, and what we pray for, is a low trajectory where there is the virility of the virus decreases, and maybe it becomes sensitive to temperature and humidity. That is an optimistic scenario. I'm not sure what will happen. But what is need of the hour? The need of the hour is testing, testing, and testing, particularly of those coming in with respiratory symptoms. It is essential to separate them in the hospitals. We need two-stage preemptive testing in symptomatic elderly immediately to reduce deaths. Immediate and continuing serological surveys are needed to monitor the stage of the epidemic. We are currently flying totally blind. We don't know at what stage we are. So test, test, and isolate. Another very important thing, the ventilator demand is going to be almost 1 million. And it is estimated that current availability in India is around 30 to 50,000. The US has 160,000 ventilators and they are running short. But I'm sure our Honorable Health Minister has taken several steps to see that ventilators are being made by local companies or being brought in immediately from outside. Mortality in healthcare workers is the biggest issue, and that can further increase deaths in the general population. So they have to be given the PPEs or protective personal equipment. If they get infected, the whole healthcare system will collapse. So it is a priority. I think it should be a priority for the government to supply free PPEs to each and every healthcare worker. Now, how infected is India? We see right from the first case that was reported on January 30, we are somewhere down here. This is April 6 data, and the first March death was reported on 13 March. We are somewhere there, so we are increasing, and this is the current data. The current data is updated for about 11 hours ago. We have more than 6,800 confirmed cases, 5,950 active, 641 recovered, 229 deceased. So we are in a bad shape. There is no doubt. Okay. Now there are certain myth busters I must talk about. Does COVID-19 spread through chicken, eggs, and meat? No conclusive evidence. Pets, not seen, but recently it was reported in a lion. Dead body, we don't know, but it does not appear that a dead body can transmit the virus. We do not have a vaccine at the moment. It is still underdeveloped. Does it affect old people? Yes, it does affect all the elderly people, especially with pre-existing disease. Now, it is said garlic is the cure. Sorry, there's no scientific evidence. The incubation period is up to 5 days. No antibiotic is effective. And if you hold your breath for 10 seconds without discomfort, it says that you don't have COVID. Even that is not very correct. It does not prove whether you have an infection or not. Now, coming to our own speciality, are patients with hypertension and diabetes at an increased risk? If you see the mortality data, and this is a wonderful meta-analysis by Dr. A.K. Singh from Kolkata, hypertension, these are the patients who are non-survivors. Hypertension, 20.7%, diabetes, 10.5%, CVD, 7.4%, smokers, 10.7%. So these were the high, and COPD was only 2%. I was surprised to see why COPD is showing less and why smokers are showing more. It is possible that smokers may have a higher AC2 gene expression in lungs, but we don't know. But we have to take this data also into consideration. Now, the most frequent comorbidities reported in the studies of patients with COVID-19 are treated with AC inhibitors. And there was a PubMed search on February 8, 2020 by a group of authors who possibly put the thing that instead of giving AC inhibitors, one should be using calcium channel blockers to suppress the increased AC2 expression or activity. But let me clarify one thing here. The AC2 is the receptor that allows the coronavirus entry into the cell. It is a full-length form. It is a membrane-bound enzyme. whereas shortened or soluble form circulates in the blood at very low levels. Now, AC inhibitors do not inhibit AC2 because AC and AC2 are absolutely two different enzymes. So there is no data supporting that the RAS blockers, that the AC inhibitors and the ARBs facilitate coronavirus entry by increasing AC2 expression. In fact, animal data supports a potential protective pulmonary and cardiovascular effects of elevated AC2 expression. And all the various societies, the American Heart Association, the American College of Cardiology, the International Society of Hypertension, the European Society of Cardiology, Hypertension Canada, they have all given an unanimous statement that treatment with RAS blockers should not be discontinued because of concerns with coronavirus infection based on the currently available evidence. So it should be very clear. And if you look at those people who died or who had severe illness, look, diabetes was commonly seen in patients who had severe COVID-19 and those who met the primary endpoint. And non-survivors, there was a jump from 10% to 20% in those who had diabetes. So what are the effects of COVID-19 on diabetes and how to prevent? But let me make one thing very clear. Not all diabetics have increased risk of COVID-19 infection. A young man, 25, 30 years, newly onset diabetes, well-controlled diabetes, no comorbidities, there is no increased risk. His risk is similar to any healthy person. But who has the higher risk? Higher risk is those who are elderly, uncontrolled, multiple comorbidities. But the problem is when they develop, anybody who develops a diabetic, when they develop a COVID-19 infection, they are going to have more severe symptoms and complications. And they are going to have worse outcomes. That is the biggest problem. Now, how do we reduce? What do we tell our patients with diabetes? This is very important for all the general practitioners who are dealing with patients with diabetes. What do we tell them? Simple hygienic measures. Wash your hands thoroughly and regularly with soap and water. Do not run after sanitizers. Simple soap and water is more than sufficient. Sneeze and cough into your sleep. When using tissues, immediately dispose of them into the garbage as soon as possible and wash your hands afterwards. Avoid touching your eyes, nose, and mouth. This is very important. Regularly clean commonly used surfaces and devices you touch or handle, maybe the computer mouse, the knobs, the lift buttons, etc. Try to avoid contact with people who have symptoms of cough, fever, or upper respiratory illness. Don't travel, as simple as that. And if you have fever, cough, or difficulty in breathing, seek medical help immediately with your healthcare provider. And if you have scheduled a visit to a doctor, bring him up, ask him whether you can get telemedicine consultation. Now, it is very important to stay at home, stay safe, stay away from work, stay away from school. And if I hope all those patients of diabetes more than 60 years should have taken their influenza and pneumonia vaccines, though this is not the time to give them. So what to do? In a patient who's already known diabetes and he develops a COVID-19 infection or suspected COVID-19 infection, he should immediately maintain an open communication with the primary care physician with whomever he has been following his advice. And he must listen to his advice regarding what medicines to use and what not to use. He should be educated about how to detect hypoglycemia and symptoms of hyperglycemia. He should keep simple sugar tablets or glucose tablets in case he goes into hypoglycemia, which is, as I said, because of the glycemic instability, there are quite big chances. He must have glucagon available in case there is a significant low blood sugar. And he must have ketone strips available in case of illness, especially patients with type 1 diabetes, who will be able to test whether they are having acetone in the urine or not. They must stay hydrated, have unsweetened drinks on hand, and practice eating smaller, frequent meals more often. Have enough medication, device supplies like pumps, pen, monitors for 1 2 weeks in case you cannot go to the pharmacy to refill your prescription. You must have extra rubbing alcohol, sanitizer, soap, etc. Now, certain drugs that may come into the picture. There have been queries about whether we should continue with DPP4 inhibitor. Now, let me tell you one thing. The role of DPP4 in coronavirus infection is an emerging issue. It may be affected, we don't know. Coronavirus could bind to the human DPP4 receptor. We are not sure at the moment. But there is a very nice experiment using type 2 diabetic transgenic mouse models who had DPP4 receptors on pulmonary alveolar cells, and the infection was with MERS coronavirus infection severity. And it was seen that those who had DPP4 receptors, they had greater weight loss, more pulmonary inflammation, macrophage infiltrates were similar to those seen in severe disease. Though we need further research whether it really binds to DPP4, and if it does, perhaps we may be able to exploit the therapeutic benefits of DPP4 inhibitors in these patients. As far as SGLT2 inhibitors are concerned, of course, they should be stopped in all patients with moderate to severe infection. But one thing we must tell all our patients, please do not stop or change any of your medications, including blood pressure medications, without discussing with your healthcare team. The risk of death from coronavirus is quite low, and most people with COVID-19 will have a comparatively mild illness. One should give a positive approach to the patient. Another question very often asked, should we wear a mask? So-called the N95 mask, which went out of the market. Now, everyone need not wear a mask. The N95 masks or the surgical masks were meant only for those people who have symptoms like cough, fever, or difficulty in breathing, or when you're visiting a healthcare facility, or you're caring for a COVID-19 suspect or a confirmed patient, or you're a healthcare worker yourself attending to patients with respiratory symptoms. So that was the current understanding till recently. The Center for Disease Control website showed that we should go for universal masking, and it is now also being followed in certain states in our country. What they say is that everyone should wear a cloth face cover, not necessarily an N95 mask, but a cloth face cover when they have to go out in public. For example, to the grocery store or to pick up other necessities, even if they are healthy. That is important. So cloth face coverings should not be placed on young children under age 2. In fact, they should not move out, or anyone who has trouble breathing, or of course who is incapacitated otherwise. Now, it is basically meant to protect other people in case you are infected and ill. So we are protecting the community. That is important. Do not run after a mask like N95 masks, which are meant for healthcare workers. Now, mask, whenever we go out with a mask to a public place like grocery shop, that is not an excuse not to maintain social distancing. So always continue to keep about 6 feet between yourself and others. This cloth mask will not prevent you unless you also maintain physical distance. They spread, they will control the spread of infection when used in conjunction with hand washing and physical distance. I once more emphasize that this face mask do not be complacent. It has to be along with regular hand washing and physical distance. And which cloth mask to use? Do a light test. The less light that passes through the mask, the more effective it is. People even have used old bras. 2 to 3 ply masks, extra fabric will help filter out the particles. Or you can put a vacuum filter or a coffee filter. And if you want to sterilize, use the hot water cycle in the washer and heat dry. Do not use synthetic fibers. Another question very commonly asked is about the prophylactic measures. Should we be taking hydroxychloroquine? Now, let us be very clear. The ICMR has given clear-cut indications who should take prophylaxis. Asymptomatic healthcare workers involved in the care of suspected or confirmed cases of COVID-19. Asymptomatic household contacts of laboratory confirmed cases. My dear friends, I have got queries from my doctor colleagues who have closed their clinics. If your clinic is closed, if you are not seeing patients, there is no need to take hydroxychloroquine. But for these two group of patients, only hydroxychloroquine prophylaxis is needed. And when you're giving hydroxychloroquine for prophylaxis, the dose is 400 milligram twice daily on day 1, and then 400 milligram once a week for 7 weeks. This is the dose recommended by the CDC. Now, of course, a baseline ECG would be ideal because we all know that hydroxychloroquine causes QTc interval. But when you are giving in prophylaxis to a person who does not have a cardiac disease, you can ignore that. But it is always good to have a baseline ECG and to see whether the QTc, corrected QTc, is less than 470 to 500 QTc. So what are the treatment options? There are multiple treatment options. I don't want to go into details, but let me tell you that they're all experimental in nature. We have the direct acting agents. The best promise or the most effective has been hydroxychloroquine, which we all know is anti-malarial, anti-inflammatory. And then, of course, the favipiravir has also shown a favorable effect, though people have also used azithromycin and lopinavir. Now, amongst the monoclonal antibodies, tocilizumab has shown steroids in the initial phases of the cytokine storm, and then vitamin B3, I'll talk about it. But two newer things that are being tried now are ivermectin and plasma therapy. Plasma therapy from those patients who have been cured of COVID-19 are having possibly the IgG antibodies, and their plasma is being now given to seriously ill patients. It is still an experimental mode, but then desperate times calls for desperate measures. Here are the dosages. I will not go into the details, but yes, vitamin B3, we know that it can boost the immune response. Even zinc can be helpful in those who are having zinc deficiency to improve the antiviral response and systemic immunity, and it can also inhibit viral replication in those. Again, the role of vitamin D, we don't know, but yes, if the patient is vitamin D deficient, obviously this should be given to those patients. Now, the initial is when the viral response phase is there, and there you can give all these drugs are started immediately, and in the later on when the host inflammatory response starts, possibly steroids in the earlier stages can help. Now, patients have been, those who are confirmed COVID-19 positive may be either asymptomatic and require home quarantine. Those who are symptomatic have been divided into 3 categories. Category A, that is the mild symptoms. Category B, that is the moderate symptoms. And category C, that is the severe symptoms. Category A, there is no risk factor, no pneumonia, chest X-ray is almost normal or minimal infiltrates, they can go for home isolation. Category D, moderate infection who have risk factors, pneumonia, but no ARDS. They have bilateral infiltrates in the X-ray. The CT scan shows no ARDS. They require hospital admission. And category C, those with pneumonia with ARDS, septic shock, etc., they require ICU admission. And this has the protocol from the infectious disease. At this stage, it is very important to realize when we are undergoing social isolation, we are under tremendous stress. Now, while the stress response is essential for survival, failure to cope with the stress can impair the function of the three regulatory systems, the nervous, endocrine, and immune, and prevent effective communication between them. So what do we get? We see people who are having anxiety, depression, mood disturbances, memory problems, addictive behavior, fear of the unknown, suicidal tendencies, and many other things, especially those who are elderly, who are living alone, and even the young people who have been very active throughout their lives. So how to avoid? Maintain usual waking hours. Don't take it as a paid holiday. Do your regular exercise. Have a nutritious diet. Develop a creative hobby. This is the time to develop a hobby. Play online games. Maintain contact with your relations and friends via phone, WhatsApp, FaceTime, etc. This is the time that requires basically a good social bonding. So what we are talking about is not social isolation, but physical distancing and physical. Parenting can become a big problem during lockdown. Now, you must help your teens, your teenagers, to how they connect with their friends through video, phone calls. They must continue with their studies regularly. They must exercise, meditate, and follow the rules of social distancing. And they must follow it as a consistent daily routine. To tackle the emergency, I must congratulate our Honorable Prime Minister and our Honorable Health Minister, who has converted the huge system of railways from 2,500 coaches into quarantine wards. So now we have more than 40,000 beds available only in the railway. And on an average, 375 coaches are being converted per day. So the Indian Railways, they are going to modify 20,000 coaches and ultimately can accommodate 3.2 lakh beds. This is called a farsightedness or vision. So friends, to wrap up, delays in testing are seriously reducing the ability of the population to protect itself. This is the most important way in which we can contain the epidemic. Test, and isolate. An increase in official number of detected cases in the short term could encourage the population to take distancing more seriously and will reduce panic compared to a big spike later. If we do not test today, we may be in we may be living in a fool's paradise that we are not in. While international transmission was important in the first stage, domestic transmission is very much relevant now. So all movement has to be totally stopped. Now, whether to lift lockdown or not, as I said, it can be either a staggered lockdown or continue lockdown for till 49 days, a decision which is more of a political, economic, as well as a medical decision. It is very important that we healthcare workers should be prepared for a very high caseload, and this should be of the highest priority of all those who are dealing in hospital health. We are optimistic and we hope that temperature and humidity increases should help us in reducing the load. Although the evidence is limited, it may be possible. I'm not saying it is possible, or we are just hoping for it. We need to focus today both on children under the age of 5 and elderly, so that there is early testing in healthcare in this population, and this could reduce the mortality toll of people. We should be prepared for multiple peaks, especially later in the year or during the winter. Every adversity is an opportunity, and I'm sure this crisis will also end with a healthier society. Let us look at the positive side. This lockdown for 21 days has possibly been an answer to pollution health emergency. No longer we see any pollution around. There are no traffic accidents. TB notification will increase because people with simple cough will go for testing for TB. There are going to be long-term reduction in typhoid, diarrhea, and jaundice due to the hygienic measures like hand washing that we will be employing very frequently. Long-term reduction of the flu season in the coming months. And most important, we will all remember the importance of family bonding. Friends, let us keep our hopes alive and our attitude positive. Remember, even the darkest clouds have a silver lining. This is a wonderful diagram I got, which from A to Z tells us everything from avoid crowding and zero face touching. I'll not go into the details, it can be seen in almost every media. But I will end with a thought that this serious crisis has to be taken as a real chance for all of us to rethink our own lives, thus turning into moral, social, and scientific rebirth for the entire hard-hearted world of today. We were living in actually a fool's paradise earlier, a most materialistic world. Specifically, for people living with diabetes, the COVID-19 pandemic even is more complicating their lives, what I term as sugar pills. And our role is to do all our best to give relief to them as much as possible. And if they happen to be hospitalized, to guarantee them the best therapeutic options, which can be quite different from those to be used in people without diabetes. Thank you, friends. My email is here, but if there are any questions, I'm ready.
Wonderful, sir. Thank you for such an elaborate and directional, presentation, which I'm sure the attendees have really enlightened themselves with the flow of how COVID-19 really came into existence, to what are the confusions, who should wear the mask, how a mask should be worn, and from there, how to manage a case of COVID-19 in their clinic. Uh, I open the floor for discussion. Is there any questions which Dr. Virmani can take? I would be happy to help him out with the questions.
Sankat, I hope my voice was clear.
Yes, sir. Your voice was much clearer and was specific as well. It was nice. So we have our first question from Dr. Pankaj Kashyap. He asks you, sir, patients that are recovering from COVID-19, what medications are processing amongst them?
What medications?
What medications are processing amongst them? So basically, I think what he's trying to ask is, what are the medications recommended for a patient who is recovering from COVID-19?
Okay, a patient who is recovering from COVID-19, he may be recovering either because of his own immunity or possibly because he has been treated in a COVID-19 hospital. So if he has been treated in a COVID-19 hospital, obviously he doesn't require any other medicines except immune boosting medicines, like as I said, possibly vitamin D3, zinc, and maybe vitamin D if he is deficient. As far as diabetes is concerned, uh, if the patient has not been hospitalized and he has been well controlled on oral drugs, we will continue with the oral drugs. But if he was hospitalized, shifted to insulin, we will continue with insulin for at least 15 days to 21 days till his blood sugar stabilizes, and then possibly shift to the oral later on.
Thank you, sir. Sir, there had been a big discussion, a dilemma when it comes to ACE inhibitors and the ACE hormone causing, the worst outcomes in COVID cases. And there had been statements coming from multiple societies and associations behind it. So we have a similar question from Dr. S.K. Panda, who asked you, ACE inhibitors, are they safe in COVID? What are your comments?
Yes, sir, Dr. Panda. The as I said, the expression of the AC2 enzyme, which is the where receptor for the coronavirus, is a different enzyme from the AC enzyme. So what we are using is AC inhibitors and not AC2 inhibitors. Now, AC inhibitors and the ARB, the RAS blockers, at the moment, there is no evidence to show that they increase AC2 expression. Since they do not increase AC2 expression, and there is no evidence to show that it can lead to increased susceptibility to infection or more complications, all the societies concerned with the cardiology and hypertension have given an unanimous agreement that we should not stop because the benefit is far, far more than any risk that we are hypothesizing at the moment.
Great, sir. So we have another question. It seems to be very interesting and apt when it comes to diabetology that we have in the background. So the question is being asked by Priyadarshan, and he mentions he asks you, you said that SGLT2 should be discontinued in a COVID patient. Can gliptins be initiated, or is there any other directions that you look at?
I talked about DPP4 inhibitors. They are basically gliptins. At the moment, we know that DPP4 expression was seen in the experiment that was done. It was with the MERS virus. So whether the coronavirus attaches itself to the DPP4, we do not know at the moment. But even if it does, perhaps DPP4 inhibitors would be more protective in nature rather than harmful. So if your patient is on a DPP4 inhibitor, please continue.
Wonderful, sir. So any comments on statins and pioglitazone? Asked by Dr. Sudhir Jha.
Yeah, Dr. Sudhir, statins should be continued. The benefit is far superior as far as the cardiac complication is concerned. As for pioglitazone is concerned, of course, if the patient goes into acute respiratory infection or into moderate to severe infection, pioglitazone should be stopped because ARDS may be confused with heart failure and patient may be prone to heart failure. So it is better to avoid. But otherwise, if the patient is well controlled, asymptomatic, he's on small doses of pioglitazone like 15 milligram, I don't think there's any harm in continuing.
Great, sir. So, as per you, if there is no symptomatic problems, and if the patient is tolerating pioglitazone, he should continue rather
Yes,
than changing. Okay,
yes.
sir. So there was a question again from Sudhir Jha. He was asking what was hydroxychloroquine used in Italy and Spain. Any idea, sir?
Yes, it was initially it was used in China. It was also used in Italy. And recently, yes, yesterday, a wonderful paper came from France where they used more than 1,000 patients, and they've seen that almost 80% of the patients who put on hydroxychloroquine, they were they were be able to recover within a period of 5 to 7 days, which was very dramatic. So I think it is appears to be a wonder drug, and recently in US they've started a randomized clinical trial, which at this time of epidemic has a lot of ethical issues. I don't know how they're going about it, but then yes, since we are getting results, and in fact in our own country, in Jaipur, Dr. Keswani, and then our friend Dr. Rajkamal Chaudhary and Dr. Hemshankar Sharma from Bhagalpur, they have also treated 5, 6 patients with a combination of hydroxychloroquine and azithromycin with excellent results. So the main crux of the take-home message is that in desperate times, you require desperate measures. And if you are getting good results, let us hope we continue with that.
Wonderfully said, sir. So we have another question here coming from Sandeep Mane, and he mentions. Just to give you a background, sir, there had been concerns with general practitioners when the COVID pandemic initiated. they started shutting down their clinics, but now slow and steadily the clinics are opening. And the concern and the problem, or rather the dilemma that still lies is, what level of protective equipment should we carry? Is the masks only okay? If the mask should be covered with a shield? So what is your direction for, a general practitioner who wants to treat his patients and he is scared of COVID?
Okay, now that's a very excellent question and a very tricky question. Now, there are two types of doctors right now, one who are practicing in hospitals and one who are running single doctor clinics. Now, those who are in practicing hospitals, they'll of course go to the hospital. But even in the hospitals, let me tell you, all the OPDs have been closed. As far as those who are running single doctor clinics or running their own OPDs, now it is majority of them have closed because we still do not know where we stand as far as the number of infected cases are there outside. The question is that every patient that comes to you, earlier we used to say that he's a potential litigant. Now I'm saying that he can be a potential source of COVID-19 infection. We don't know unless he is tested. He may be asymptomatic. So if you want to open your clinic, it's your personal decision. Nobody can force you. And if you are opening a clinic, well and good, please take the proper protective equipment, which means at least an N95 mask, a plastic shield, a goggles, and a plastic cover for the whole body, and employ that you have social distancing in the waiting room of your clinic, that you have give appointments to the patient. Do not allow more than one relative to enter along with the patient. There should be no overcrowding either in the clinic or outside the clinic. And every person should be screened outside by your staff or a worker that he's not having an influenza-like illness. If he's having, he should be referred to a COVID-19 designated hospital immediately. And you must see cold cases. And even with cold cases, you must employ your hand washing technique, your sanitizing all the stethoscope and blood pressure instrument, etc. And when you're examining the patient, try to examine him from a distance, try to go more on clinical history, and perhaps use the digital blood pressure recording. And maybe instead of auscultating, you can ask for a chest x-ray, because this is the time we can't be examining our patients as we used to examine on a regular basis.
Wow, wonderful, sir. That, I think, clears out most of the questions that would come in if anyone wants to ask you on how to practice and what to be taken care of when practicing. Sir, there is a question that has come up which says, there are multiple, as you mentioned rightly, N95 masks. So the question lies on the similar lines. It says there are different types of masks available. Can we use a simple home cotton cloth for saving ourselves from the contagion?
See, those simple masks, which as I the cloth masks, as I said, number one, you must see that they are effective, the light should not pass. Number two, they are meant for from preventing spreading infections, not for you getting infections. That's very important. So these masks are meant for when you are going out, for each and every person who goes out. But if you are a healthcare worker, these masks are not going to work. You need an N95 mask, or you need a double surgical mask if you cannot get an N95 mask. For a healthcare worker, the whole situation is different.
True, sir. Uh, Sir, also there is a question now. If you see, most of the contacts are being kept under isolation and sometimes also called as quarantine. So there is a big dilemma as to who is the quarantine and what is quarantine and what is isolation, and what is the impact of it to people who are listening to it. So if you can just elaborate on that.
Absolutely. The difference between isolation and quarantine is that quarantine is meant for suspected cases who have not yet been proven. Isolation is for those who are proven cases, who have been tested by maybe antibody and PCR, and they are proven, so they are isolated. Now, you can also say they are also quarantined. But when you are putting a person on quarantine, it is not isolation, because then he may not have been positive. Or he may even be positive, still we'll call it quarantine, because we do not know unless we test. So the moment you test him and he becomes positive, we call it isolation. So it is basically a semantic difference between isolation and quarantine. But as far as the physical process is concerned, it remains basically the same. That is total physical distancing, and the person is not allowed to meet anyone. He's isolated in a single room, and he's got his own bathroom, and food is served to him in the most sterile conditions possible.
Okay. So there is another question that walked in. It says, "What do you see as the outcomes of early easing of the lockdown?"
Uh, See, this is, as I said, if I showed you a cartoon where after 21 days, when you try to lift the lockdown, there is bound to be a spurt of cases. Because there may have been number of cases who have been asymptomatic or infected during this 21 periods, because as you also know and as I also know, that it is not possible for 100% compliance as far as physical distancing is concerned. And we have seen the results. There were spurts of cases during two occasions. Now the question is that if we stagger it, perhaps you lift the lockdown for 2 days, and this is basically not to improve the economy, not to let the people go back to what they were doing earlier. This is just to see that people who are stranded somewhere, they are back in their homes, just to give them that time window so that please rush back to your homes. And then you again continue for a lockdown for, I think, at least 30 to 35 days. So that minimum of 49 to 50 days total lockdown will only prevent this totally flatten the curve, so that maybe after 49 50 days we may not see any spurt of cases immediately. Maybe we may see during the winter months, we don't know, but at least we'll not see in the next 2 to 3 months. But again, I must also say here, once the lockdown lifts, life will not be normal. Please do not think that we'll be going back to our routine life. We will be more safe. We will be washing our hands frequently. We will be maintaining physical distancing. We will be seeing patients one by one. We will not be allowing overcrowding. We will not be going to public gatherings. We will be avoiding public gatherings. So these things will remain, and they are going to remain for a long, long.
Thank you, sir. So there is this question coming from Dr. Sandesh Gupta, and he mentions like all the diabetics currently are under a lifestyle modification. They have a set curriculum that they do, so that, for example, they get up early morning, they do some yoga or exercise or a walk, following which they get into a diet which is restricted. At the same time, it is measured properly, following which in the evening they have a routine separately. So coming to that question, sir, coming to with that background, under lockdown the physical activity is minimal, and which may adversely affect the diabetics in terms of maybe diet or the things that he's consuming, or the movement that he plans, the exercises that he plans. So what all should be done by the patient to safeguard from diabetes during such lockdown, which can include diet or exercise, or just to maintain a proper euglycemic profile, sir? Any comments on it?
That's what exactly I meant by sugar tension. When I said sugar tension, the new term that I have coined, it basically means that because of the lockdown, there are certain restrictions. The regular exercises that you're taking outside the house, you cannot take. The availability or scarcity of fresh vegetables, fruits, nutritious food may be hampered. So, but still, at least in your house, maintain your regular waking hours, do your regular yoga, do your regular exercise, have small, frequent meals, take all your medications, monitor your blood sugar intensively, maybe twice a day if you are on insulin, or at least once in 2 3 days if an oral drugs, and maintain your routine life as if you are doing everything from the house. Uh, as simple as that. I know it's difficult to imagine at the moment, but then we have to change the way we work, the way we do things. That's all. We have to accept reality and change ourselves.
Thank you, sir. So there is another question which says, "What is the new theory of porphyrin hemoglobin? Are we heading? Are we headed towards the wrong direction?"
See, that again is an hypothesis. We don't know. As I said, it is that the surface proteins of the coronavirus attacks the heme of the hemoglobin, and so that there is increase of iron in the blood. Perhaps that is why we are seeing increased serum ferritin, and because of that, the chances of there is less hemoglobin. So, and because there's less hemoglobin, there is a difficulty in the carbon dioxide oxygen exchange by the lungs, so they get intense inflammation. So this is just a hypothesis, and possibly because of that, chloroquine is also acting. We don't know. This is an hypothesis given by somebody and who has got data from number of hospitals. At the moment, it is very difficult to say how far it is true, but it does seem to be plausible at first sight, and I somehow agree that possibly it could be one of the reasons.
Okay. So there's this question coming from Dr. Kotwal, and he mentions, what are the why are the elderly more susceptible and with high mortality rate as seen in China and Italy?
Elderly often have reduced immune function. That's a part of the aging process. They have multiple comorbidities. They have hypertension, diabetes, cardiovascular disease. So obviously, elderly are they may have been having nutritional problems. They may be having mental problems. They may be having suffering from Alzheimer's, dementia, and other symptoms. They may be living alone. So all these factors, when you take into account, elderly as such are more prone to infections. And when they're more prone to infections, whether it be corona or be any, it hardly matters.
Thank you, sir. Uh, so there is this question from Dr. Dhirendra Pratap Singh, and he mentions a 22-year-old male patient visited his clinic with complaints of high fever, 2 days with anorexia and extreme weakness after 2 days. He developed loose stool and pain in abdomen. What would be your comments for such patient?
See, as I said, we are still learning about this virus. This virus is hardly 4 months. So, whether this patient has a COVID positive or not, only testing can tell us. But we have to keep our a very high index of suspicion. If he has been traveled outside somewhere, maybe even domestic, or he has come in contact or is coming from an area where some cases have been reported, this is a very high suspicious case. Because I'll tell you what happened. There was a wonderful report that I came across in Agra, where a person had returned on the first week of March from abroad, and he was tested, he was negative. 1 month later, his mother was admitted in the hospital. She tested positive, and she died. And the whole family was tested, all were found to be positive again. So that 1 month gap, we don't know what the virus was doing or where the virus was lurking. Patients are presenting with pain abdomen, with diarrhea. We don't know what is happening. We are still playing blind. So it is very important to realize that any patient with fever, any patient you cannot give a cause to fever, please treat him as a potential COVID-19.
Thank you, sir. So there's a question on hydroxychloroquine. Now, hydroxychloroquine, as you also mentioned, and ICMR also recommended, that can be taken for as a prophylaxis. So, this prophylaxis of hydroxychloroquine, how long? When should you start, and how long do we continue for it?
The prophylaxis of hydroxychloroquine is not for everybody. It is only for asymptomatic healthcare workers and asymptomatic persons who have come in contact with the positive cases. Please remember these two scenarios very important, and it is meant for them and them only. And there the dose is 400 milligram twice daily on the first day, followed by 400 milligram once a week for 7 weeks.
Sir, any prerequisites that needs to be done for before you start the hydroxychloroquine prophylaxis?
Yes, ideally one should do a baseline ECG because it is known to prolong QT interval. But at the dose that we are using as a prophylactic, I don't think it may be required in young persons or persons with no history of cardiac disease. But yes, definitely in elderly persons or history of cardiac disease because we have used this molecule in patients of rheumatoid arthritis and we have never done routine ECGs earlier.
Great, sir. Thank you, sir. I think everyone on the comments page or the chat page is thanking you for the wonderful talk that you have provided. It has solved many questions, many concerns, many doubts in their mind towards COVID-19, towards managing diabetes in such a situation. Even the part where you highlighted about the psychiatric manifestations which a patient would fall in trap with when it comes to a lockdown, when it comes to a restricted lifestyle and less job to do at home, which you guided rightly by doing his regular routine, his exercises, and also yoga or meditation, which can really help. Also, I see that you have also shown about the railway booths, how they have been converted into isolation wards so quickly that the capacity can be doubled overnight for the patients. So a great thanks to you for highlighting all the excellent points and directions for us to be safe and well read about this topic, sir. Thank you very much,
Thank you, Shankar. I'd just like to say one thing
sir.
that I'm proud to be in India with a leader like our Honorable Prime Minister, who is leading not only India but the whole world against in this war against this coronavirus.
Great, sir. We are proud ourselves. Thank you, sir. Thank you for your excellent presentation today. Thank you.
Thank you.